Thank you, Mr. Chairman. I was intrigued with your testimony in regard to the secretarial authority to alter or eliminate cost sharing based on the evidence of the value of services. And I was wondering if you could expand on that, because one of my concerns would be is that I understand if something has a high benefit, lowering that copay, but you could theoretically raise the copay so high that people couldn't afford it, even if they really wanted to do that. And I'm concerned that for a particular patient and a particular doctor, they may make a decision that perhaps universally might not have great benefit, but could to that patient. I was wondering if you could expand on that. And
yeah,
my thought was maybe put caps on the high end.
Yeah. So as you know, a number of private insurers and employers have been moving towards the idea of value-based insurance design. Typically, the focus has been on reducing patient copays for services of high proven value. An example would be having low copays for services provided to diabetics or patients with multiple chronic illnesses to make sure that they get the care they need to prevent worsening of their health and potentially higher bills as a result of that. There has been less done in terms of increasing copays for low value services, probably for the obvious reason that that's more controversial than reductions are. So I would anticipate that at least initially, most of what the Secretary might do with this authority is lower copays. That said, there are services that sometimes can be quite expensive, but are of low value to patients. And rather than prohibit access to those services and say, oh, you're a Medicare beneficiary, you can't have that service at all, the idea would be to say, okay, you can have it, but you're going to pay a bit more of the cost of that service if it's a proven low-value service.
And I don't come from a medical background. Can you give me an example of one of those that across the country would have a low benefit and might need to have the fee raised?
Since I'm not a physician either, I would be reluctant to do that. What I would say is that this should be done thoughtfully, and it would be done as part of a notice and comment rulemaking process. So the Secretary would have to publish the evidence to support this low-value assessment, and all relevant parties would have the opportunity to contest that evidence and respond to it. And I think that's the way it ought to be decided by experts, not by people like me.
As a representative of the public, and while I generally think experts do a pretty good job, sometimes I have big disagreements with them, and I would just have to say that while I kind of like the idea, Mr. Chairman, I would want to see if we were to authorize the Secretary to do that, I would want to see some kind of a cap on the top of the as a top number, so that you wouldn't be in a position where suddenly a procedure is completely voided because the cost is just so horrendous that nobody can justify it except for the extremely rich. So I do appreciate that. With that, Mr. Chairman, I will yield back my time.
Chair, thanks, gentlemen. Now I recognize the gentleman.